The frontal lobe has prefrontal and precentral areas. The precentral area controls voluntary movement of the trunk and limbs on the opposite side, and movements of the eyes, the tongue, larynx, pharynx, and much of the face on both sides. Known as the first somatomotor area, it includes the precentral gyrus, the posterior parts of the superior, middle, and the inferior frontal gyri, and medially the paracentral lobule. Its arrangement is somatotopic. That is, it reflects that of the body, in this case inverted, with the face below and above in the paracentral lobule, the toes. The amount serving each part is proportional not to the bulk of muscle moving it, but to the skill with which it is moved. Representation of the hand and face is accordingly considerable. Damage to the area, due to a stroke for example, in this case on the right side, may result in paralysis affecting principally the left side. Afferent fibers reach the first somatomotor cortex from the prefrontal and sensory cortex, and from the cerebellum and basal ganglia via the thalamus. The first somatomotor cortex has motor and premotor parts. In the motor part, pyramidal cells pack the plexiform layer. Their axons pass to the nuclei of the cranial nerves as the corticobulbar fibers and into the spinal cord as the corticospinal fibers. As they pass through the brainstem, they form ridges called the pyramids. The fibers are hence known as pyramidal fibers. Although most efferents originate from small pyramidal cells, about 2% come from giant ones in layer 5 called Betz cells. Their size may be associated with the length of their axons. They are most common in the area which serves the lower limb. Betz cells are absent from the premotor area, which is thought to store patterns of motor activity assembled through experience. The frontal lobe contains other motor areas. The supplementary motor area controls the same areas as the primary cortex, but if damaged, does not cause paralysis. The frontal eye field mediates voluntary eye movements and involuntary reflex eye movements such as following moving objects. Stimulation of the area causes conjugate movements of the eyes, particularly towards the opposite side, compensatory movements of the head, and widening of the pupil. Broca's area, the first motor speech area, lies in the inferior frontal gyrus of the dominant hemisphere. Damage here causes motor aphasia, a loss of the ability to speak, although the muscles involved are unaffected.
Checker, flag, not checkers, flag.
Patients can understand words when they see or hear them, and can think and write them, but are simply unable to say them.
In my head, no problem. It's words, his lips. How can I express? His lips, it's a big problem.
The prefrontal cortex is concerned with emotion, personality, and judgment, as well as visceral functions such as heart rate and blood pressure. It's connected with other areas of the cerebral cortex by the superior and inferior fronto-occipital fasciculi, with the opposite side through the corpus callosum, and with the corpus striatum, thalamus and hypothalamus, the limbic and reticular systems, and the cerebellum. Damage to the prefrontal cortex may cause flattening of mood, loss of initiative and memory, concentration, and self-neglect. The reverse, with disinhibition, aggression, and overactivity, may also occur.
My memory is like getting a brush of paint on and flipping on the wall. Where the paint lands is where my memory remembers. The big gaps without any obvious pattern.
The parietal lobe contains the first and second somatosensory areas and part of Wernicke's area. The first area receives sensation from the opposite half of the body, the same side of the mouth, and both sides of pharynx, larynx, and perineum. Information relays in the ventral posterior medial and lateral nuclei of the thalamus then radiates out to the cortex. Anteriorly, it is granular, with a prominent outer layer of biaget, reflecting the number of afferents it receives. Behind it is agranular. Like the motor cortex, the sensory cortex is somatotopically arranged. The amount of cortex serving each area depends upon the amount and intricacy of sensory information arriving from it. Representation of the hands and lips is enormous. The second somatosensory area receives sensory information from both sides of the body, but especially the opposite side. The remainder of the parietal lobe is so-called silent association cortex, which interconnects the sensory areas within the same side, across the midline, and with the thalamus. The parietal lobe is important for discrimination, for example of 2 points from one to the other, for learning, and particularly for interpretation of language on the dominant side, where part of Wernicke's area is located, and of spatial information on the other. Damage here may result in agnosia, for example, lack of awareness of bodily parts. Astereoagnosis, failure to recognize objects by feel alone, is also characteristic of parietal lobe lesions. The occipital lobe is separated from the parietal lobe by the parieto-occipital sulcus. Medially is the calcarine sulcus. The area between the two is the cuneus. Almost the whole lobe is occupied by the visual cortex, the termination of the optic radiation. The first visual area lies in the calcarine sulcus. The cortex, which is granular and very thin, contains at least 1/10 of all the neurons in the cortex. Because of the large number of afferents, the outer band of biaget is marked and stripes the cortex, hence the name striate cortex. Each visual area receives information from 2 half retinae of the same side, representing the half visual field of the opposite side. Arrangement is retinotopic, that is, it reflects that of the retina. Superior retinal quadrants are represented on the superior wall of the calcarine sulcus, and inferior quadrants on the inferior wall. Fibers from the peripheral retina of both eyes project onto the anterior parts of the visual cortex. Behind, macular input accounts for 1/3 of the total. The second visual area surrounds the primary, whose input it relates with previous visual experience, enabling recognition. It also contains a motor area, the occipital eye field, which is involved in conjugate eye movements, particularly the reflex ones involved in following and fixing on a moving target. Efferents pass via the superior colliculus to the nuclei of the extraocular muscles. The occipital eye field is also connected with the frontal eye field. The temporal lobe is important in perception, language, and hearing. There are 2 acoustic areas, the first in the lateral fissure on the anterior transverse temporal gyrus, and the second below in the superior temporal gyrus. They receive auditory information from both ears, but mostly the contralateral. Impulses pass via the medial geniculate body in the auditory radiation of the internal capsule. Lesions of the primary acoustic area affect the ability to locate the source of sound. Only slight bilateral deafness, greatest in the ear of the opposite side, results. Lesions of the secondary acoustic area cause difficulty in interpretation of sounds, word deafness. The second speech area of Wernicke lies partly in the parietal lobe, but mostly in the temporal lobe of the dominant hemisphere. It's connected with the visual and auditory cortex, and with Broca's area. Lesions in Wernicke's area cause receptive aphasia, a difficulty in understanding the spoken and written word.
Picture the thing around her to know what she wants to do, and that she will inside let it all, and it will be quite nice for them, I think.
Although speech is fluent, the patient is unaware of the meaning of the words he says, and may produce non-existent words.
They'll be really in the colour for roots there. HOLAD, a shadow, no. I will take it with myself for the evening, for my evening meal. And it's rather beautiful that it's very round and light round, and looks, it's very tidy, pleasant.